sinus, atrial, junctional, nodal, ventricular, blocks, others. Rhythm recognition. Sinus, atrial, junctional, nodal, ventricular, blocks, others, aims and objectives. To be able to calculate heart rate from ECG. To understand features of normal sinus rhythm. To recognize rhythm abnormalities from a variety of causes. To understand rhythms which may need immediate, emergency action. Calculating HR. 1500, small squares. 300, large squares. Is it normal sinus rhythm? Rate 60 to 100 BPM. Regular P wave to each regular QRS. Normal P wave appearance. Normal and constant PR interval. Sinus node rhythms. Sinus tachycardia and sinus bradycardia. All features of normal sinus rhythm, except rate less than 60 BPM, bradycardia. Rate greater than 100 BPM, tachycardia, sinus arrhythmia. Rate 60-100 BPM. Varies with respiration, more common younger. Retains all features of sinus rhythm, except regularity of QRS complex. Usually cyclical, sinus arrest. Time period without sinus node activation. Clear pause and normal rhythm. Often terminated by escape beat. Rhythm before and after usually normal. SAR block. Blocks occur as a multiple of the PP interval. Measure out. Non-conducted beat from normal pacemaker. Rhythm before and after normal. Atrial rhythms. Premature atrial ectopic beat. Premature firing of atrial cell, faster than SAR node. Earlier complex. Compensatory or non-compensatory pause. Return to normal rhythm. Premature atrial ectopic beat. Run of premature atrial beats. Can occur in isolation or short runs. Atrial bigeminy, trigeminy. Longer runs should really be termed as SVT. Symptoms, really. Causes, more often in older pits. Lung disease. Stimulants. Treatment, antiarrhythmias. Wandering atrial pacemaker. Irregular rhythm. Multiple atrial pacemakers firing at own rate. Different P-wave morphologies. Different P-wave distance from QRS. Different QRS rate. Atrial tachycardia. Ventricular rate greater than 100 BPM. Atrial rate 160-250 BPM. Varying levels of conduction, 1:1, 2:1, 3:1 etc. P-waves abnormal or not easily seen. Sometimes seen as part of T-wave or QRS. Atrial tachycardia. Symptoms. Palpitations, which can be skipping, fluttering or pounding in the chest. Chest pressure or pain. Shortness of breath and fatigue. Fainting, also known as syncope, or near syncope. Lightheadedness or dizziness. Causes cardiomyopathy, chronic obstructive pulmonary disease. Ischemic heart disease. Rheumatic heart disease. Sick sinus syndrome. Digoxin toxicity. Treatment depends on the type and severity. Medications, antiarrhythmic drugs. Radiofrequency catheter ablation, RFA. Cryoablation. Atrial flutter. Atrial rate 250-350 BPM. Usually regular QRS, can be variable conduction. Most commonly 2:1 conduction, 150 BPM ventricular and 300 BPM atrial. Classic sawtooth. Atrial flutter. Causes me and ischemic heart disease. Hypertension. Cardiomyopathy, congestive heart failure. Mitral valve disease. Symptoms. Palpitations. Syncope and sob. Angina. Anxiety. Treatment digoxin and sotalol, lowers ventricular rate. DC cardioversion, RF ablation, anticoagulants, stroke, atrial fibrillation, irregular QRS. No P waves, atrial rate greater than 350 BPM. Fast or slow avenue conduction. Irregular baseline, atrial fibrillation. Causes: mitral valve disease, thyrotoxicosis, cardiomyopathies. Symptoms: often no symptoms, lightheadedness and dizziness, palpitations, chest pain. Treatment digoxin and sotalol, lowers ventricular rate. DC cardioversion, AF suppression, pacemakers, RF ablation, PVI, junction and avenue nodal rhythms. Junctional premature contraction. Premature beat originating from avenue node. May be antegrade or retrograde P wave. Compensatory, non-compensatory pause before restoration of sinus rhythm, junctional escape beat. Failing of normal pacemaker, SAR node. Pause in electrical activity, sinus arrest. Escape mechanism from further down in pathway. Avenue node, slower intrinsic rate. Junctional rhythm. Rate 40-60 BPM, avenue node intrinsic rhythm. Regular. P wave retrograde, antegrade or none. No SAR nodal activity. Pacemaker avenue node. Conduction normal from this point. Accelerated junctional rhythm. Rate 60-100 BPM. Otherwise maintains all features of junctional rhythm. Junctional tachycardia. Rate greater than 100 BPM. Maintains all other features of junctional rhythm. Avenue nodal re-entrant tachycardia. Re-entry circuit in the avenue node, abnormal pathway to ventricle. Commonest type of SVT. Rate usually 150 plus BPM. Ventricular rhythms. Ventricular premature contraction. Premature firing of a ventricular cell. Ventricles already depolarized before SAR node impulse conducted through. Wide, bizarre complex. No P wave. Often normal variant that can be associated with ischemia, ventricular ectopic beat. By Gemini. Trigamini. Ventricular escape beat. Pause in regular activity, for example sinus arrest, slow AF. Ventricular focus takes over as an escape mechanism. Wide, bizarre complex. Usually followed by restoration of underlying rhythm. Idioventricular rhythm, ventricular escape rhythm. Rate 20-40 BPM, intrinsic ventricular rate. Regular rhythm. No P wave. Wide abnormal QRS. Usually connected to third degree HB, accelerated idioventricular rhythm. Rate 40-100 BPM. Exactly same features as ventricular rhythm. Ventricular tachycardia. Rate 100-200 BPM. Regular. Occasional dissociated P waves. Wide, bizarre QRS. LBBB and V1 indicates VID origin, pulse. VID also associated with VF, brugada. RBBB and V1 indicates LV origin, usually no pulse. Other features to distinguish VT. Capture beats, normal looking beat. Occurs at exactly right time to be conducted through. VT continues immediately following. Fusion beats, combination of sinus and ventricular beat. Torsade de points. Twisting of the axis. Rate 200-250 BPM. Regular or irregular. Sinusoidal pattern. May revert to VF or back to senior. Associated with electrolyte abnormalities. Ventricular fibrillation. chaotic ventricular activity. Rapid contraction, unable to produce cardiac output. If patient is fine and awake, it is not. Check leads or get defibs. Heart blocks. First-degree heart block. Rate depends on underlying rhythm. Regular. Prolonged PR interval greater than 0.2 seconds. Physiologic block in the avenue node. Caused by medication, vagal stimulation, disease, morbid size second-degree HB. Wencker-Bach. Rate depends on underlying rhythm. Regularly irregular. Increasing PR interval. Dropped beat. Cycle starts over. Diseased avenue node with long refractory period. Morbid's 2 second-degree HB. Rate depends on underlying rhythm. Same PR interval for all conducted beats. P waves usually regular. Some P waves not conducted. Can be 2 to 1, 3 to 1, 4 to 1 etc. Usually progresses to CHB. Complete heart block, 3rd degree HB. Atrioventricular dissociation. Regular P waves. Regular QRS. No relationship. Rate depends on intrinsic rhythm, for example escape rhythm. Needs pacemaker. Other rhythms. Asystole. No cardiac activity. Check leads. Resuscitation. Chest compressions may cause ECG waveforms. Important to stop to assess rhythm. Usually poor prognosis. Check for P waves, may respond to pacing.